Well, today in First Psychology, thank you very much for being here. Note to self and others, I will be very repetitive today simply because there's a lot to cover, and also there are multiple ways to interpret every slide that I will be about to show you. What is the topic of this week's lecture? Psychotherapy and integrative therapies. This is something that we discussed in the past a little bit, especially in the context of psychopharmacology and psychopathology. But today I will dig deeper into the different modality, strategies, and school of thoughts in psychotherapy. So already at the beginning of this lecture, I would like to really quickly define the terms. So on one side, we have psychotherapy, okay? Psychotherapy. And attached to this, I will call the, integrative, complementary, and alternative modalities, okay? Now, yes, we do have multiple lectures and playlists on each of this, but I would like to mention this. What used to be a complementary approach a few decades ago now became standard of practice in psychotherapy, but there are still some modalities of psychotherapy that nowadays are no longer utilized. Are they still valid or not? How can we pick psychotherapy? How can we pick a good therapist? These are the questions I would like to address this lecture. So let's begin right away with some analysis of what we're trying to do here. So if you meet a patient for the first time, how are you going to approach this person? Well, you will have to ask questions. I would say that the biggest part of any work in psychotherapy is asking questions. And as we will see, certain branches of psychotherapy will ask more questions than others. In some other forms of therapy, you will still ask questions, but without using words, without using the top therapy modalities. And one of these approaches is the approach in art therapy. So one of the methodology in art therapy is called the lifeline. And just to give you a practical example right away, if you meet a patient for the first time and you do this lifeline exercise, as the name implies, you will ask the person to perhaps draw a line just like this one, okay? And assuming that this is the ground zero, so this is birth, as much as the patient remembers it, okay? And this one is, let's call this an X, okay? This is the present moment, okay? Now, I mentioned this in week 1 and 2 a little bit. So this should serve as a form of visual journaling, okay, like a diary. Now, there are multiple ways to do this exercise, but I want to use this as an example. So if this is our life, okay, and assume that you can divide this somewhat evenly, okay, in decades, okay, so this is the age of 0, this is the age of, let's say, 10, this is 20, this is 30, okay, and the X represents 40-ish, okay, something like that. A patient in her is 40. Then you can add multiple things to define what's happening here. Now, if you remember the example I gave you, is that let's assume that the patient wants to discuss the triad, the thought, the behavior, and the emotion, if you remember the cognitive CBT triad, right? So let's assume that with the color green, okay, we talked about social aspect, friends, interaction, relationship, okay? And let's assume that on top, right here is an indication of the goodness, okay, of situations, and down below here, the bad, okay, of the situation, okay? So anything that's above the midline is good, anything that's below is bad, and there's a gradient. So let's assume that a person, based on what the patient remembers, was experiencing a relatively happy childhood, okay? And these are the social aspect, the family, relatives, etc. The person might start something like here, okay? And then, around 10, all good. Then in elementary, middle school, things start to go down a little bit. A friend move was really bad. They missed that. And they start to feel better around 20. Their socializing aspect was still good. And then they had heartbreak, and they lost all their friends because their friends were part of their relationship, and things start to go better. And now there's someone like here, okay? So in green, okay, we call this the social aspect, okay? It's a little vague, but that's, you know, how we can start a conversation. And then in red, we can associate emotions, okay? Not necessarily strong or weak, but good and bad, oversimplifying things here. So we start to attribute something here, okay? And something here, okay? With the assumption that right here you have the neither or. Now, as I said, pretty happy childhood, so this will be okay, but there was something that was not as good. He remembers at the age of 8 to be very shy, or to be very much of a loner, and still had a lot of friends, but nothing too well, okay? And then there's something like, I don't know, they had other circumstances, and he remembers feeling very, very happy at the age of 16, but then this also impacted them, and then he was pretty good around 20, and then he was very, very sad here, but that was a big relapse, and then still feels a little sad here. Emotions, okay? Right here, emotions. Emotions, okay? And then perhaps with blue, we can call these achievements, okay? Achievements, okay? And let's say, well, pretty low at first because they didn't have anything to compare themselves to, but they were slightly successful in school, but then middle school, not really good. It was really bad, really struggled all through college. And then eventually something went better in university. They felt really good. They had a great job, but then as of late, they really lost everything. They were laid off, or they were fired, etc., etc., etc. And now we ask them to perhaps associate their mental health. Now you might wonder, is mental health related to social aspects, emotional aspect, and achievements or goals? Yes, of course, but we're asking the patient to identify specific events in their mental health. And they might say, well, it was pretty flat for the first, 8 years of my life. And then I was diagnosed with ADHD when I was 12, okay? And so my mental health really went down, and it pretty much stayed there, okay? Then, yes, I started feeling better. I stopped taking medication. I felt pretty good, but now things seem to be going in the same direction, okay? Now, this is art therapy, expressive art work. What is this? Is this psychotherapy? Well, at the very least, we could say that we're not asking questions directly. We ask the patient to work on this, but then, as you remember from week 1, we can infer certain things based on this diagram, this graph. So for instance, if you remember, if I were to look at the age 10 here, let's do this. Let's do this screenshot here and identify perhaps, I don't know, this is the age of 14 and a half, something like that, okay? So what's happening here? Well, in terms of mental health, things were pretty bad, okay? So let's take a look at achievement, also very bad. And you might start to say, well, perhaps there is a causal link, or at the very least a correlation between, I made up the diagnosis now, ADHD and poor academic achievement, okay? They didn't perform well in school. What else was going on in their life? Well, the emotions were pretty okay overall, okay? Maybe not as good as the patient remembers them years prior to that, but in terms of social aspect, things start to go down. Are those two related, okay? Maybe part of the social interaction were connected to the way they felt in school. Maybe all their classmates were doing very well in math, and this person was not. Or maybe they were very good in sport, and this person was not even able to focus on playing basketball, for instance, okay? So let's continue. Those lines here seems to be pretty high, so let's call this maybe 26 and a half, okay? What's happening here? Everything starts to be okay, socially, emotionally, achievement, and mental health pretty okay. But then around, let's say, maybe 27 and a half right here, something changes, okay? So the red line is still holding, okay, still pretty high, okay? But what's going down is the social aspects, okay? And pretty soon, as you can see here, the emotion are following. But you see that both mental health and achievement were going up. So there seems to be more of a correlation here between emotion and society than between either society and mental health or emotions and achievement, okay? And you can learn different patterns here. And at this point, despite the fact that a person feels that mental health is going down, and at this point, even their emotions is going down, then what is going better overall is the social element. Okay, so you have a lot of information here in terms of what the patient can do. Now, we will see some examples of art therapy, but overall, we could say that there are different ways to incorporate arts in psychotherapy. So psychotherapy, as it implies, is the work on the psyche. So on one side, you have talk therapy, and on the other side, you have medication. But even within talk therapy, you might incorporate things from behaviorism, from the cognitive school of thought, from family system and group therapy. You might incorporate things from positive psychology or humanistic psychology, Carl Rogers, for instance, some elements of psychodynamic, psychoanalytic, analytic psychology, Carl Gustav Jung, Sigmund Freud, Otto Rank, Claudio Rizet, and all the names that we encountered briefly last week. But you also need to understand the goal. So if we were to think about the application of arts in psychotherapy, it's a good idea to just remember the origins a little bit. I promise this will not be about history. I will not ask you to remember any dates, but just a general understanding. So if we do have arts, okay, or the arts applied to therapy, you might already see that within arts, you might have things such as visual art therapy, okay? So visual simulation, you might have music, okay? And then you might, within music, you might have dance, okay? You might have movement alone, etc., etc. Okay? How much of this is based on science, or at least science informed, and how much of this is directly applicable to art therapy? Let's take a look at the visual component. Well, first of all, by visual, we already mean something that usually can be discussed, okay? And in fact, a huge part of the discussion in arts has to do with interpretation. So in this sense, you already have a form of art therapy, one could argue, in the application of the Rorschach ink blot test, which we've seen last week. So what do we mean by interpretation? The interpretation presupposes the existence of a goal, okay? The existence of a clarified goal that has to do with what we're trying to achieve. And that will separate the different types of arts. So you could have, based on this understanding, expressive arts, which are art in support of therapy, which can be leisure, like the person is in an inpatient psychiatry unit and might work on arts and crafts, free expression, playing around. In itself, it's therapeutic, of course, but it's not guided and it does not contain any specific therapeutic goal or diagnostic goal, as in the Rorschach ink blot test. With expressive art, of course, the connection is also with what? With forms of art such as art brut in France, arte povera in Italy, and some evolution of this, such as outsider art. Notice this is really a big summary, because I have another lecture series on the arts in psychotherapy, but this is just an intro. What's the difference? Well, art brut and arte povera is really a form of art that can be considered an art movement. Think about Jean Dubuffet, for instance, right? Or Carlo Rovelli in Italy. So artists that express some connection with primitive, more instinctual form of arts. And this is also connected to the way art is collected. Think about the collection by Hans Prinzhorn in Switzerland. And the outsider art is an art created by individuals who, beside being artists, are individuals suffering from mental health disorders. So in that sense, they're outside of the quote unquote normal art system. What I always mention is that you could have some outsider art on one side and art therapy on the other side. The main difference is that they might create the same thing, but the goal of outsider art is free expression as in any other art system. The goal in art therapy, as the name implies, is to heal, treat, or cure a problem. Okay? Now, of course, there's all overlap. But what is the other issue is that the system of outsider art was created with the intent of protecting individuals suffering from mental health, who otherwise are considered to be good artists, from the negative effect of societal stigma, so to create a parallel system of arts that will allow them to exhibit their work. The downside of that is that you attach a label, you're no longer just an artist, you're an outsider artist. So what will happen if you feel better, if you're no longer taking medication, for instance? Are you still an outsider, or once healed, then you become just a normal artist? Those are all controversial and philosophical considerations to take into account. But what I'm trying to say is that whatever strategy you take, there's always an element of expression in psychotherapy. And I will show you some examples later. But to go back to the more standard forms of psychotherapy, what do we mean by psychotherapy? Well, the application of everything we study so far in psychology to help people. That will be a good summary. So, question for you. If you are a therapist, okay, and you want to take on a behavioral approach, what do you think you will do? A behavioral approach, okay? Let's wait a few seconds so you can think. All right. What would it mean if you take on a cognitive approach? What about a social approach? What about a biomedical? Etc., etc. Those are just examples, of course. But if you were able to answer these questions, you already know what type of direction psychotherapy will take. Because based on each of these school of thought, and there are many more, of course, you will also determine what type of discussion patterns you will use in the session. Now, on top of all of this, you have to distinguish the type of science you trust in psychotherapy. Now, careful here, I'm not trying to say that you just need to pick and choose which science makes sense to you, but at the very least, you need to decide what constitutes evidence. This is going back to week 2 in our semester. So for instance, if you trust only what is scientifically observable, you might really have hard time with anything that is psychoanalytic. Notice, you're not necessarily saying that everything that Freud has ever written is completely false and it's a lie. You simply say that I don't really see any evidence. I cannot scientifically observe anything about the id, the ego, etc., or the subconscious motives, etc. So you might say, okay, what is scientifically observable? Well, you could say that short of neuroscience, and even within neuroscience, everything is about interpretation. And so you might take one direction if you're a hard behaviorist and you want to take into account, let's say, conditioning as an explanation of the way the person behaves. But even in that case, you need to decide how much emphasis you want to put on how you can change their behavior, because after all, we can be conditioned to think, feel, and behave a certain way. So this is just an overall understanding What I'm not going to do in this lecture is to do some role modeling. I do this from time to time, in fact, many times, in person when we have the course offered in the classroom on campus, because I like to customize the way I approach people based on the needs of the moment. And this is not a clinical course per se, so I rather not do this online because it's hard to answer the question on the basis of these examples. However, there is plenty of information for you to research if you're interested in developing your psychotherapeutic techniques. And yet I had to say this, do not try these at home, because this is a very complex clinically, scientifically, ethically, area of psychology that I really do not advise to practice just for the sake of trying something out. There are some exceptions to the rule. For instance, you'll see that we'll be talking of some motivational interviewing techniques and some discussion on, let's say, the trans-theoretical model of change by Prochaska and Di Clemente, the stages of change model. Now, those areas of counseling or coach intervention can be practiced, in steps without thinking of major dangers. But for anything that has to do with true psychotherapy, whether psychodynamic, psychoanalytic on one side, or behavioristic, cognitive behavioral, dialectic behavioral therapy on the other side, I strongly encourage you not to improvise. This is a very difficult profession, and so I hope that I will stimulate your curiosity and you will study more if you want one day to incorporate that into your career and your life.
Beginning with some perspectives, some quotes here by Mario Bunge and Armand Rousseau. The ancient Greeks made much of the difference between episteme or science and doxa or opinion. The postmoderns deny this difference, but the rest of us have kept it because we care for truth and well-grounded action. The worst man of science is he who is never an artist, and the worst artist is he who is never a man of science. In early times, medicine was an art which took its place at the side of poetry and painting. Today they try to make a science of it, placing it beside mathematics, astronomy, and physics. These two quotes should serve the main purpose of understanding where psychotherapy finds its place in psychology. We already talked about psychology as a science, and we already mentioned the fact that when one is thinking about liberal arts, then the difference between, let's say, STEM fields, STEM, and other fields such as medicine or poetry in this case, should not be a difference of quality or quantity, because liberal arts would indeed contain all of the above. And so when we think about psychology and we want to apply psychology in a healing profession, the same should be said about psychotherapy. So on one side, psychotherapy is both a science as well as an art, but at the same time, we have to be extremely careful with some postmodernist claims according to which any truth is the truth. Any truth is subjective, and therefore any type of therapy is subjective. There is no ultimate universal truth, no ultimate universal healing. So it doesn't really matter what type of therapy or what type of therapist you are seeing. Now, in the next slide, we talk about complementary, alternative, and integrative approaches to psychology and medicine. I'd like to include this slide, this picture, this meme, because it makes fun of certain presupposition that at times we have in the West when we think about complementary medicine. So on one side, we have the rejection of anything that does not fit the paradigm of, for lack of a better term, extreme capitalistic big pharma, for which if you don't prescribe a medication, then you're not really doing anything for the patient, as opposed to thousands and thousands of years of tradition, medical tradition, healing tradition, that attempts to better understand who we are biophysiologically on one side, but also psychologically and spiritually on one side, so that medications are not everything. Surgery is not everything. But the questions remain. When we think about integrative approaches to medicine or to any healing healthcare profession, the questions should be, does it work? Is it safe? Is it real medicine, as in, is it real treatment? And is it based on real science? So already here you can say that any type of postmodernist claim fall apart if the postmodernist claiming would be something along the lines of, well, it doesn't really matter what type of therapy you use as long as it helps you. This really, really seems to be similar to, well, if it's good for you, it must be good for you. If it feels good for you, it must be good for you. Because if there is no objective truth and no objective science, then the question, is it based on real science, falls apart. Now, if one were to ask the question, well, this is completely irrelevant. If it works for me, that is enough of a proof for me. It works. I feel better. I'm good, and that's all I need. Then the claim might be, well, there is no ultimate truth. But the fact that you're stating that is in itself an assumption of an ultimate truth. In other words, stating that there is no such thing as an absolute reality is an absolute statement in itself. All right, so in this lecture, we'll try to bridge the gap between the biopsychosocial model on one side, the biomechanical model on one side, and see what else is there in terms of therapy. Now, keep in mind that when we think about psychology and psychotherapy, we went through a lot of changes in the last 200, 250 years, especially in the West. So what seems to be the standard of care now used to be treated as alternative not a long time ago. The best example is probably analytic psychology, psychoanalysis. Okay? It was really much fringe, quote-unquote science, if not considered entirely pseudoscientific. And the opposite happened as well. Now, for instance, if you think about the way lunatic asylum used to be viewed in the past, they were sort of prisons, and they were meant to control individuals that were deemed to be either dangerous or at the very least inappropriate for self or society. Okay? Think about the treatment in terms of insane, okay? The insane asylum, right? So think about the chair that people were fastened to, or the bed, right? So this individual were treated in a very inhumane way. And then you have things such as ECT, or electroconvulsive therapy, the former electroshock, which is still in use. I would say is especially used in the United States, not so much or not to the same extent in the rest of the world. And as the name implies, ECT, electroconvulsive therapy, induces a seizure, a mild seizure, a pseudo seizure that disrupts the patterns that are observed in a normal state of affair. And the assumption here is that this will interrupt or disrupt, create a break into the disorder the person is suffering. Now, ECT is being utilized for many, many decades for depression, but especially in the United States, it's starting to be utilized for a variety of I would say, psychiatric presentation. Okay, so the idea here is that this generalized seizure, albeit without convulsion, without muscular convulsion, okay, is utilized to manage things such as major depressive disorder, catatonic states, mania, etc. And it is administered under anesthesia with the muscle relaxant. But again, if one were to say, how does it work? Why does it work? That is the biggest question. Because, for instance, ECT has been used, I would say worldwide, for schizophrenia as well. But the North American attitude toward it is in response to little response to treatment standards. So if a person shows little response to, let's say, the standard medication, antipsychotic, then this is comprehensive evidence, research evidence for the utilization of ECT. This is to say that without going into the details of ECT, there are a lot of concerns about the way it is utilized and what type of mechanism actions are actually happening. And this is really not well, I won't say it's not well studied, but it remains a mystery, okay? In fact, there are plenty of meta-analysis and reviews, and the current state of affairs, it's the end result, which is a model of disruption of neural circuits followed by augmented neuroplasticity and rewiring. That's the idea. So you interrupt and you recreate. So there's a lot of controversy about electroconvulsive therapy or electroshock. Okay, keep in mind that the way it was first utilized was to anesthetize cows, so not human beings. In Europe, especially in Italy. And so it was not first thought to be utilized in a therapeutic session. So ECT would be considered a fringe form of therapy in comparison to the standards of care, and that's what it's utilized in alternative or as a follow-up for treatment-resistant presentations. And then you have other things such as TMS, transcranial magnetic stimulation, repeated transcranial magnetic stimulation, which are purported to disrupt these depressive electrochemical brain patterns. Okay, so or repeated deep brain stimulation, right? Utilizing implanted electrodes, but this is not something that is just part of the last 20 or 50 years. Psychosurgery was utilized many decades ago. Think about the current state of affairs in microsurgery, which again, as the name implies, might work by disrupting these neural networks, especially in the context of pathologies and presentations such as aggression or specific areas of OCD or lobotomy. Lobotomy was part of psychiatric treatment for many decades, and it's horrifying to think about it nowadays, and yet it was predicated upon the same thing, this destruction of the connection between the frontal lobes and the rest of the brain, right? So of course, the idea is that this will decrease depression. If you're lobotomized, you will experience less depression, but it will also destroy anything else that makes you human, really. So any type of judgment or thought process, cognition, initiative, and so on and so forth. So the question is, again, are we talking about real science here or not? Another quote here by another philosopher, Ludwig Wittgenstein: "In psychology, there is experimental method and conceptual confusion. The existence of the experimental method makes us think that we have the means of solving the problems which trouble us, though problems and method pass one another by," which is another great question when one is to study psychotherapy. How do we know that the research indicates what it seems to indicate? Okay? Because, as I mentioned multiple times this semester, the way you frame the question will also determine the result. Okay? So that we are doomed to find what we already wanted to find in the first place. So the question may be, is psychotherapy effective in general? Okay? And we will see there are very different modalities and models of psychotherapy. And there are different ways to measure whether psychotherapy is effective. Okay, one will be whether the client, your patient, is satisfied. I mentioned this multiple times. I prefer to use the term patient than client out of respect and also integrity toward both the patient-provider rapport and also the profession. They're not paying us for a service. They're seeing us to receive some advice and healing. So more than just a client, a patient. Okay, so psychotherapy is effective if your patient is satisfied, okay? Or whether the patient appears to perceive, sense some level of amelioration or improvement. Or if the therapist sees improvement, which is another very important aspect. Sometimes the patient will not see improvement, but everybody else will. Okay? This is a common pattern, especially in depression. If you're depressed, very often you will fail to see how much more strong your parents are and more balanced your outlook life is in comparison to everybody else observation. The opposite could happen as well, where there is minimization and magnification. So we'll see how those plays out. But it's important for the therapist to also observe an improvement, okay? And whether there are some, measured values in comparison to before and after therapy, okay? So the other question would be, okay, so how do we measure that, right? So we measure effectiveness and efficiency and efficacy. So you have the usual case control, the control group not receiving the intervention, okay? And you also have to utilize observable measures of symptoms, okay? So not just perception. And that's precisely why in our discussion on the DSM, we talked about statistics and we talked about traits, we talked about clusters, and we talked about the way a psychiatric label is applied to the patient. Because otherwise, if you don't decide those labels, that there's nothing you can measure, right? Now, another question, what causes improvement, right? Sometimes this is just due to regression to the mean. I mentioned this last week, right? So if you have a test, a psychological test, a personality test, you take it once, you might be presenting yourself, if not a complete outlier, then you might receive more of a stronger diagnosis, and then you retake the same test, and you're more normal than previously displayed, right? So you regress to the mean. There's a drifting from an initial crisis back to an average state, okay? This is one of the potential confounder when one person appears to feel better, but it's just a question to understanding the regression to the mean. Or the patient's motivation the patient motivation is to appear better than he or she really is, to please the therapist, okay? And so when you try to understand the statistics, you need to understand what we mean by the quote-unquote average psychotherapy patient versus the average untreated person, okay? And that data is pretty straightforward. Now, depending on which type of therapy, we're talking about 80% of untreated people have poorer outcomes than the average treated person in general. But does that mean that any therapy it's good? Well, at this point, you should have some understanding of the modalities, okay? Of the modalities of psychotherapy, and if you understand those modalities, then you should also understand what theoretical framework they're based upon. Okay, so let's assume that, for instance, you have to think about behaviorism. Okay, you should remember everything we said about Thorndike and Skinner and Watson, and you also understand that there are different ways to look at the problem, okay? So, for instance, going to the next slide, okay? There are main forms of psychotherapy in the US, and there are main models of psychotherapy. For now, if you want to understand the focus of this lecture, think of psychotherapy as therapy predicated on talkative understanding, so talk therapy to treat mental health disorders. Psychotherapy is the general umbrella term. Within psychotherapy, you have psychoanalysis or psychodynamic therapy. Think about Freud, for instance. Now, in this picture here, I wanted to represent Freud in a different light, so to speak. There's, of course, Sigmund Freud here, but in the same picture, you see also his two sons, Ernst Freud and Martin Freud, and they were very, very patriotic. They fought in the Austrian army during World War I. They were very involved in the conflict, this horrible conflict that destroyed Europe first, and then the Western world, the world in general afterwards, and they were taken prisoners because Italy won World War I against the Austro-Hungarian Empire and Germany, and of course they finding the Austrian army they were kept prisoners. But this is just a different light for Freud, because we tend to think of Freud only in terms of the theory of dreams and libido and Eden as. So it's just different picture here to create more of a humane and maybe like family-like presentation of this founding father of psychoanalysis. Then you have humanistic, client-centered therapy, and we'll discuss each of these. And humanistic, you have to think about things such as the evolution of, let's say, coaching or counseling in the US, motivational interviewing, for instance, the patient-centered approach, and even the trans-theoretical model, the stage of change model. Not you worry, we'll be talking about each of this, but also the role that the philosophical focus on the person plays a role. Behavior therapy, which of course has to do with the utilization of conditioning models, right? So classical conditioning, operant conditioning, which we talked about multiple times in this semester. Cognitive therapy, okay, and as it implies, focus on thoughts. And then we'll see that both behavior and cognitive therapy will merge eventually, creating what is called cognitive behavior or cognitive behavioral therapy. And then you have interpersonal and transpersonal forms of therapies, which of course are, you could say, to some extent connected to the humanistic and client-centered therapeutic approach, but also go beyond that, okay? In terms of transpersonal therapy, we should also think about transpersonal psychiatry, okay? It has to do with going beyond the person, not transhumanism, nothing to do with this, again, postmodernist, AI-informed, quote-unquote, moving past the human being, okay? Nothing to do with that, okay? Not transhumanism. In the next slide, you have 5 main models, which, again, are the same, but also explain why certain models are attributed to certain scientists and they, so to speak, present specific modalities. The psychoanalytic or analytic model, I mention this because there is quite a big difference between, let's say, Freud and Jung, as much as there is a big difference between Adler and Rank, or let's say between Ehlers and Beck, etc., etc. Okay, so there is a commonality of approach at the very beginning, mid-1800, but then everything kind of started to be separated. Okay, then the behavioral or behavioristic model, okay, depending on how much emphasis there is on the behavior itself. The cognitive or quote-unquote choice control model, because the idea is that if you can understand your thought and you can monitor your thought, then you can control your thoughts. So the way you feel is ultimately your choice, okay? Which is a criticism against certain elements of behaviorism, whereby there is no free will. You're just an outcome of whatever stimuli you have out there. The humanistic or person-centered model, and again, that's why it's not transhumanistic, okay? You focus on the person. One of the criticisms, of course, is that if you focus on the person and the person is the only thing you judge everything by, so everything is subjective, then the discussion of the ultimate truth falls apart, as we mentioned earlier in this class, okay? And finally, in this slide, the family group model. Those are not completely separated, but of course, one of the main idea in psychotherapy is that it is an individualized treatment, okay? Same person, not a system form of therapy, okay? Now, what does the research indicate? Well, there are different types of approaches that work best with different types of psychological issues, with mental health problems, okay? So for instance, to treat depression, both cognitive behavioral therapy and psychodynamic therapy appear to be quite successful in different ways. They also work well for anxiety, but anxiety also benefits from exposure therapy. In turn, exposure therapy is good for phobias, okay? And then you have some elements of, let's say, behavior conditioning that might be useful for both psychosomatized issues or issues of development. Think of bedwetting, for instance, okay? So how should we choose the form of therapy? Well, you had to think about a evidence-based clinical decision-making process, okay? Best research studies, okay? clinical expertise of the therapist, because that is both an art and a science, okay? And then, of course, you need to be respectful and aware of the patient's outlook, the patient's values, the preferences, ethics, morals, etc., preferences, and circumstances, okay? So to review all of this, pros and cons. Well, in the psychoanalytic model, the problem is that you might have, first of all, the idea of this unconscious, subconscious thing, conflict that you need to uncover, okay? There could be an issue of transference and counter-transference, where there is a transfer to the therapist from the patient, or counter-transference from the treatment psychologist to his or her patients, okay? So that there are all these elements of projection, for instance, that play a role. So it's a very intimate situations that challenges boundaries, okay? Especially because of the use of association, free association, word association, germ interpretation. And from a scientific standpoint, it's really difficult to demonstrate the existence and the modalities, the mechanisms, the patterns of all these subconscious elements, okay? And there's some level of suggestion, right? Because if you think about free association, during a psychoanalytic session, the patients will be free, speak freely about all the dreams and memories and feelings, and then there's interpretation that follows the suggestion by the therapist to follow unconscious meaning and underlying wishes, right? To gain insight, and the idea is to release tension. But again, as I mentioned multiple times, okay, relief is not healing, and that's one of the biggest issues in certain modern or modernist approaches, okay? So in practice, what is interpreted in psychoanalysis? If you go to a psychoanalyst, okay, what does happen, okay? Beside the technique itself, you have different ways to see unconscious meaning in multiple areas. But I would say resistance, dreams, and transference are the three main areas. Okay, so if you have resistance, then you as a doctor will notice that your patient seems to be hesitant or blocked in speaking about certain items, certain subjects. Okay, and then if the patient is discussing with you their dreams, there might be certain patterns or themes, right? Some latent content, okay? And this is similar to what we said last week about the Rorschach ink blot test. And then there's some level of reaction toward a therapist based on the feeling that were born for someone from their life, from the past, for instance, okay? So if one were to compare psychodynamic therapy to interpersonal therapy, for instance, okay, you could say that interpersonal therapy, it's an extension of psychoanalysis. So less focus on insight, but more on this relational behavior change, okay? Less focus on childhood and the past, and more in current situation, okay, as opposed to the psychodynamic, psychoanalytic perspectives. Now, of course, there is a huge difference between psychodynamic therapy and psychoanalytic, because you could say psychodynamic is less focused on this subconscious, this id, this sex, these super egos, but more on self-awareness and insight, right? Now, what about the behavioral model? Well, we talk about the behavioral model a lot because in the module on conditioning and behaviorism, we analyze the paradigms quite in depth. So I will just mention a few things here in the context of psychotherapy. So the main idea here is to use conditioning to support, to achieve quote-unquote normal behavior, right? Now, as you can imagine, because you're observing behavior and you stimulate behavior, this model doesn't really address the main root cause, okay, of the problem, and also doesn't really contain any type of focus on free will. So really, really different from what the philosophy of human being, the anthropology of the human being, the theology of the body even, you could say, think about Aquinas, for instance, has to say about our essence as human beings. Okay, so we are treated as animals because the animal modeling in behaviors is the primary way to interpret behavior, okay? So the idea is that this behavioral model uses principle of learning, as I mentioned, classroom upper conditioning, to have reduced unwanted responses, okay? And that's why, this is very much applicable to things such as addiction, right? Or a certain type of reaction that do not fall. Now, there is a different attitude between, let's say, the US or the Anglo-Saxon model and the European model, the Central Southern European model. For instance, in the US, there's more of an emphasis of focus on response rather than a reaction. Very often in Central and Southern Europe, it's the opposite, focus on reaction rather than a response, but that's also to do with some misconception in etymology, whereby being a response sometimes is considered to be an overly charged emotional response with no higher content, versus the reaction is more based on unobservable patterns, which is quite the opposite in the US. Now, in the humanistic model, okay, as we mentioned 3 weeks ago, there is a gap. There's a distance between the real self and the ideal self, right? So there's no judgment of behavior per se. Okay, so there is a lot of focus on empathy and understanding one another. One of the weaknesses of the humanistic models is that the recovery is confused with relief. So on one side, you seem to help the patient because you're very nurturing, very empathetic, and in itself, I wouldn't say that's a bad thing, although there is some criticism in terms of the way it presents itself. But again, this is an unnecessary and I would say very unhealthy burden to the patient, because if you're telling the patient, you're the ultimate judge, if it feels good for you, it must be good for you. Whatever you say, I will support you, or even worse, I will affirm you in whatever you feel and do. That's exactly what the patient should not hear, because that's what got the patient in trouble in the first place. Not to say that the patient is responsible for everything, so to speak, that went wrong in his or her life, but if you're telling them that every behavior is justified, so you're not saying that I try to understand, but you go beyond that. I understand you, I justify you, and even worse, I affirm you in your behavior, despite the fact that your behavior is awful for yourself and others, that is really, really detrimental to the well-being of the person, okay? So the general idea is that in humanistic psychology, and the same psychologists I mentioned last week, so Carl Roger, Abraham Maslow, etc., the emphasis in this human potential for self-actualization, okay, for the attainment of a personal fulfillment, which unfortunately is satisfaction, making oneself full, okay? So there is a support for personal growth, self-awareness, self-acceptance, all of which are really healthy, especially that person has a very unhealthy sense of personal guilt or inadequacy about life. But of course, the extreme version of this are really detrimental. In terms of the labels, Carl Roger used client-centered therapy, but it's just a different, more specific style within humanistic therapy. So in practice, what is the difference between, let's say, psychoanalysis and this humanistic therapy? Well, in psychoanalysis, because of the medical background of their founders, there's more emphasis on the cure and the healing path toward mental illness, versus in humanistic psychotherapy, there's promotion of growth, which can also lead to a lot of narcissistic problems, the same one as extreme psychoanalysis has a very callous approach. Let me tell you, everything is wrong about you because I'm the only one knowing the truth. So you see that there's an issue on both sides. On one side, you have too much emphasis on the patient. On the other side, there's too much emphasis on the therapist. There can be both egotistical in nature, right? In practice, what do you do? In humanistic psychotherapy, you take responsibility for feelings and actions because you focus on yourself, versus psychoanalysis, you bring these unconscious conflicts into conscious awareness, okay? So the therapist in psychoanalysis provides interpretation, okay? Versus in humanistic psychotherapy, the therapist provides this safe space, this environment that allows personal growth to occur. In psychoanalysis, the focus is more on unconscious. In humanistic, more on conscious. And the main focus of humanistic psychotherapy is right here, right now, the present time, and of course, toward the future, versus psychoanalysis, the focus is on the past. Okay? So this has a lot to do with this element of different patterns. The group family model has to do with the person in context. Okay, so rather than focusing on the person alone, okay, it has to do with understanding in context. Now, certain critics of the group family model claim that this can be problematic for more introverted patients, for instance, right? So you have to work on both the person and the system and the family, okay? But it's also, in terms of positive thing, can be very positive, very popular as a core decision or alternative to incarceration for extreme cases, okay? There's also a financial aspect. The group family model tends to be less expensive than other treatments, especially psychiatric, heavy focused on medication or psychoanalysis. But this is just a consideration. So in practice, what is family therapy, what is group therapy, and how does it differ from the things we mentioned so far? Well, as the name implies, family therapy involves the treatment to the whole family, in the presence of the whole family, right? So working on the family system. What is the family system? It's a combination of patterns of alliances, authority, communication, which also applies to the couple therapy or marital therapy. As you can see here, there's different models within that to assess all the things that play a role in the way a person feels. Okay. In group therapy, as the name implies, you not focus on individual session, but in a group session. There is some element of group counseling or group peer-to-peer support groups. I would say that AA or NA are within the same framework. Think about Alcoholic Anonymous or Narcotic Anonymous, this peer support group, or group therapy, for instance, in an inpatient psychiatry unit, whereby you have multiple people working on, let's say, the same cognitive behavioral therapy worksheet, or you work on integrative approaches such as art therapy or dance movement therapy, or you work on things such as adverse childhood experiences, but in the context of trauma support rather than personal sharing. Because that's one of the main issues. Once you uncover a traumatic experience, and this is difficult enough in an individual session, this can be extremely detrimental to the well-being of the person if this is shared in a group. So you always have to weigh the benefits, the cost-benefit analysis in this sense, okay? Because you might have what is usually called a self-help group that can do that as well. Now, the self-help group per se, it's not a therapeutic group, okay? So it might not be healthy in terms of what type of advice the person will receive, but at the very least, the person might feel that they are better understood by peers because the peers, after all, went through similar traumatic experiences. But again, in self-help groups, the focus is more on support rather than therapy. So we should not confuse family therapy, group therapy with self-help groups. Now, how are the cognitive models? Well, one of the issues with the cognitive model is the implication that disorders are a choice, or at the very least, a mistake, a cognitive mistake. And so the idea is to work on a change of self-image, self-perception, okay? The way we understand ourselves in the context of our relationship. And that's why it's connected to the locus of control, which we mentioned last week. Okay? This could also be a problem, first of all, because it ignores more profound essential elements to who we are, but also it might create a conflict between the doctor and the patient. Now, if the question is, okay, how much of each model you find in an average session in therapy in the US. Well, there is quite a bit of research in this regard. You could say that cognitive therapy still plays a major role. I would say close to 50% is cognitive alone. If you add behavioral therapy to that, you definitely pass 50%, you're like 54, 55%. Humanistic, 10, 11%. Family systems therapy, about 20%. But again, that varies because you could use CBT techniques in all of the above, okay? And in group therapy, you use CBT, cognitive behavioral therapy, quite a bit. And psychoanalytic or psychodynamic forms of therapy are usually less than 30% in the US. So just something to keep in mind in terms of the way it's utilized and the way you're working on it. Okay, so since we mentioned the cognitive model, how much of that cognitive and behavioral therapy has its origin in behaviorism and learning and conditioning? Well, think about the classical conditioning techniques, counter-conditioning, right? So if you have been conditioned to fear certain things because you had an overreaction, a panic attack, then you could be led into the same situation. Let's assume you cannot face public parkings, okay, because you have a bad experience there. Then the therapist can lead you into be in the presence of this parking, be there, and then you can be helped with some monitoring, some relaxation exercise. So the ultimate goal, conditioning, is to associate the situation, the place, the parking lot in this case, with relaxation, okay, which is in itself incompatible with fear. So that's what you do, conditioning, okay, reconditioning, okay, which is also at the center of exposure therapy, okay. Exposure therapy is one of the essence of therapeutic approaches to trauma, to PTSD, for instance, okay? So if the idea is that a conditioned fear can worsen when avoidance of the fear situation gets reinforced by a quick reduction in anxiety, okay? And this has to do with guided exposure. So there's a habituation, okay? The person can get used to the anxiety itself, and so there's a separation there. You can tell yourself, okay, I'm here, I'm okay, nothing, you don't even say nothing will happen to me because that might lead to further rumination, but you can just start by saying nothing is happening to me right now, okay? And you start to relabel also your anxiety. Yes, this is anxiety, this is what happens to me, I recognize it, I know it, I will not let it control me, I recognize it. So I label it and I have already mastery over it. This has also to do with a lot of philosophy or even theology. If you think about biblical narratives, when there is an attribution of a name, I'll call this tree, I'll call this animal, I'll call this dog, etc. Naming something gives you power over something. Okay? Labeling something gives you power because you recognize that. Okay? If you've never seen a car before, you might be scared of that car because you don't know what to expect. But once you've seen a car, maybe you have driven a car, then you recognize, oh, that's a car. Now, of course, the car can still harm you, for instance, if you cross the road without looking before you do that. But then it's not unfamiliar, it's not a novelty, it doesn't create anxiety anymore. So there is a systematic desensitization, right, that could also occur. So it's an application of everything we said about behaviorism and conditioning techniques. Now, there are different versions of exposure therapy. So I mentioned systematic desensitization. So what is this? As the name implies, you start with a smaller version, a reminder of the fear situation, and then you keep increasing the exposure intensity as your patient learns to tolerate the previous level. So you do this step by step, right? But then you also have other types of stimulation. I mentioned olfactory virtual reality and neurofeedback, although those two things are quite separate, to obtain similar results without the same level of presence by the patient itself. Okay. All right. So in short, we can just say that in the context of clinical psychology, by exposure therapy, we mean the application of, let's say, four main principles. So you create this safe and welcoming environment where your patients can expose themselves to all the triggers, the fears, the things they need to avoid. And this happens with four mechanisms, four processes, and you should be already familiar with those because they are directly linked to what we said about learning, conditioning, and behaviorism. So those four major principles include habituation, extinction, some level of processing, emotional processing, and of course, self-efficacy. Okay, so this is just one of the things that we need to focus when we think about exposure therapy. And as I mentioned, the uses are really regarding anything that is a trigger, any type of anxiety disorders, including GAD or to treat PTSD or phobia. Okay, now there are different types of different methods, different directions that a therapist can take. If you are interested in this aspect, I'll be happy to cover them more in depth, perhaps via email, because I want to give a general overview today. But some of the forms, especially for PTSD, will include desensitization, this kind of graduated exposure, systematic desensitization, a longer exposure therapy, a prolonged, as they call it, PE, which is really behavioral therapy, and CBT, which we'll see how that applies, cognitive behavioral therapy, flooding, which is this direct exposure to a stimulus, a triggering stimulus, but at the same time, you make the person, you navigate the emotional processing to make the person feel less afraid. And then you have some form of narrative therapy, which is not the same as narrative medicine, as we'll see. Narrative exposure therapy, more specifically, which, as the name implies, will create a written account of the experiences. And it's very useful both in a individual setting as well as in the context of group therapy. Okay, but and with all of this, I don't mean to say that there's only one form. You can also have integrative forms of therapy together with exposure. What we used to call complementary and alternative techniques now are becoming more and more standard, which means that you can still use exposure and behaviorism and conditioning as an approach, but you might use mindfulness, you might work on meditation, guided imagery, body scan, and even things such as EMDR, which we'll see in a few seconds. EMDR stands for eye movement desensitization and reprocessing, which is somewhat controversial in terms of the research that promotes it, but it's something that is relatively popular in psychotherapy, at least in the United States. But if we want to have a general outlook, what is psychotherapy in terms of where does it come from and how does it apply to the modern understanding of psychology? In these slides, which I call Thought, Emotion, Actions, Is There More?, I'm trying to give you a very brief summary of what we know in terms of what brought us to where we are in the United States. So the general overview is the same one that I utilized so far in the semester. So psychotherapy comes from psychology. Psychology comes from science, from medicine, and from philosophy. Okay? Because in psychotherapy, we are talking about, for the most part, a form of talk therapy, or at least a supplement to talk therapy. So the names of Marcus Aurelius, so the Roman philosophical background, the Roman philosophical tradition, the virtus, the Roman virtus, the virtue, right? With the Greek Stoic tradition. Okay? This is the general apparatus. Now, it would be not true if I were to say that the modern psychotherapeutic techniques only come from Rome and Greece. This will be not true. But the reason why I mention this is because the tradition here is a tradition that predates, in the context of Europe, the Judeo-Christian tradition. And a lot of those therapists were utilizing some of this Stoic self-managing behavior that focus a lot on thoughts and application, and so to speak, this purification, cleanliness of thoughts in order to understand how we behave. Is this all there is or not? Now, the answer should be no, because despite of the fact that this is true for this tradition in Rome and in Greece, that tradition in itself was predicated upon many other layers of ethnocultural and even ethno-religious background. So this is kind of an extrapolation in modern term. But from this type of philosophy toward a psychodynamic or psychoanalytic form of talk therapy. So people like Freud and Jung and Rank, etc. As I mentioned a few weeks ago, this could also be viewed in reaction to this type of philosophical background, more specifically as a separation of magisteria between tradition, religion, spirituality, ethnicity, culture, society on one side, and thoughts or interpretation of subconscious, preconscious, unconscious motives and dreams on the other side. From this approach, the psychodynamic and psychoanalytical form of psychotherapy, you have a sequence of steps. Okay, now this is connected both to rational therapy and to cognitive therapy. The author here is Albert Ellis. So, in a sequence, in a chronological sequence, Dr. Ellis went from a rational therapy (RT) to rational emotive therapy, to rational emotive behavior therapy, REBT. And the idea is to challenge what he labeled as irrational beliefs and assumptions, okay? Now, this is already judgmental because you could say that in the case of Ellis, Beck, and Meichenbaum, as we will see later, this is a reaction to psychoanalysis, to the fact that there are things that should be more if not scientifically based, at least more observable. Now, we cannot read a person's mind, we cannot read their thought, but we can observe their thought process. In other words, it's harder to judge and interpret a dream than it is to interpret or judge a thought. So it's a reaction to this overemphasis to these subconscious motives according to the Freudian tradition especially, okay? Now, from RT, RET, and REBT to behavior modification. This is not necessarily a reaction, it's a completion, you could say, bringing two schools of thoughts together, the behavioral one and the cognitive on the other side. And ABA, or applied behavioral analysis, is the application of behavior modification. So that's why it's called behavioral engineering. And this is in itself based on the work by Skinner and all the behaviorists, which received a lot of criticism, rightfully so, because it completely avoids any profound discussion on free will, as if we as people are simply blank slate that are forced to be brainwashed, quote unquote, to behave a certain way. We have no agency, no self-efficacy on one side, nor free will, which is consistent with this, I dare to say, quite materialistic, reductionist view of humanity, which is close to the behavioristic approach. So it's also pretty telling that from rational therapy, you went to rational emotive therapy and then rational emotive behavioral therapy. You cannot separate those things, or you should separate them to study them, of course, but you cannot pretend that each of them does not play a role. Okay, in our understanding of ourselves and others. Now, as I mentioned, within cognitive therapy, you have many names. I only mentioned here Ellis, Beck, and Meichenbaum because they're the one that, at least in the United States, are talked the most and applied the most. So for Ellis, it's this irrational beliefs and assumption, where the assumption, of course, is there is something rational. So see, even though these were very materialistic and to some extent reductionist, some might even say nihilistic approach, the idea is that there is something that is observably true as rationality. So even in the worst case of extreme behaviorism, you never have this challenge of complete subjectivity, okay? Or everything is up for debate. There's no absolute truth. These are very important things to keep in mind in a day and age where relativism seems to dominate, okay? None of that. Some might argue that these thought processes and this evolution in a philosophical social sense was a product or a byproduct of what happened 10 or in some cases 100 years before with the Age of Enlightenment and some revolutions in Europe, the Communist, the Socialist Revolution, the Marxist Revolution, etc. But at the very least, these assumptions were now fully put into practice as it is the case nowadays, especially in the West, with absolute relativism. With Beck, instead of talking about irrational belief, you talk about cognitive distortion, okay? And this is especially true for depression. And we will see how that this is applicable in many cases because, first of all, CBT, as we will see, CBT, cognitive behavioral therapy, is the last application. CBT is the one form of psychotherapy that is applied the most in the US, also because it's the one studied the most. It's not necessarily the most effective, but it's the one that has more studies, and also it's easier to apply because it doesn't require, both in terms of the depth and the length of therapy, what is required from, let's say, analytic psychology. And then you have Meichenbaum, stress inoculation training, practicing healthier thinking before facing a stressor or a frustration or a disappointment, etc., etc. As you can see, there's a lot of focus on cognition and behavior. Now, of course, emotion plays a role, but depending what type of strategy, you might work on it before or after. The other thing is that when we think about psychotherapy, we do indeed talking about talking with people, all right? So there are some level of suggestion. So the doctor, the therapist, the psychologist might suggest alternative thoughts, alternative point of views to their clients, so that the client might start to revisit their thought in a different way. Now, when we're thinking about Ellis specifically, the idea is that depression and low moods and isolation and negativity, etc., those are worsened by irrational beliefs. Now, the idea is not that depression is entirely predicated only about thoughts, but bad thoughts make for bad moods. That's the idea. Okay? Now, with the REBT version, the rational emotive behavioral therapy, the focus is on helping your patients to notice, to bring this to awareness. Notice what? Notice that they are operating on self-defeating assumptions, okay? And so once you change the thought, you reward yourself by replacing this negative, defeating, false assumption with realistic beliefs. And we'll see how that plays a role. Now, some of these examples that are very important to mention are these automatic thoughts / cognitive distortion. Put everything into the same basket. Different psychologists, different researchers use different terminologies, but for now, I'll put them in the same sequence. So let's begin with magnification and minimization. Exaggerating or minimizing the importance of events. One might believe their own achievements are unimportant, or that their mistakes are excessively important. Catastrophizing, seeing only the worst possible outcomes of a situation. Overgeneralization, making broad interpretation from a single or few events. I felt awkward during my job interview. I'm always so awkward. Magical thinking, the belief that acts will influence unrelated situation. I'm a good person, bad things shouldn't happen to me. Personalization. Now you might think, well, what's wrong with being personable about things? Are we talking about person-centered therapy? Well, that's not necessarily what it's meant with this definition. The belief that one is responsible for events outside of their own control. Example, my mom is always upset. She'll be fine if I did more to help her. Now, careful here. We're not saying that this is not the truth, all right? Because this is also about taking responsibilities. This is more about balance. It's still what we talked about in terms of the locus of control and locus of responsibility. Finding a balance. If you personalize everything in life, first of all, you're making yourself more important than you are. As in this case, you think of that without you, that your mom will always be upset. So you have more power than what you really possess. You don't have the power to make people change completely, okay? But the opposite will also be true. The fact that, well, she's completely responsible for emotions, I can mistreat her, and she just needs to deal with it. Those are both equally bad, okay? We need to work on proper levels of responsibility. Let's continue. Jumping to conclusions, as the name implies, interpreting the meaning of a situation with little or no evidence. Keep in mind what we said about the pyramid of evidence. How do you know that this is the case? You jump to conclusion, perhaps because of previous bad experiences, perhaps because of the emotional state you find yourself in as you're thinking about certain things. But the point of jumping is that you're not seeing the full picture. You're too eager to label whatever is happening to you. Mind reading, interpreting the thoughts and beliefs of others without adequate evidence. She will not go on a date with me. She probably thinks I'm ugly. I always tell this joke. She's probably not thinking of you at all. You're transparent. She doesn't even see you. This will be the worst case scenario if a person is already dealing with some low self-esteem or depression. And yet, as you can see, there are different layers of interpretation here. Think of this example, okay? If you are tense or anxious about, in this example, meeting someone or talking to someone, you also put too much pressure on yourself. You're not as, I have to say, important or visible as you think you are. Now, being important or visible might lead you to have a huge inflated ego where you think that you're always at the center of everyone's attention, or the opposite, that if you have a chocolate stain on your shirt, everybody will notice that. Again, you're reading the mind of others. When I say, well, she probably doesn't think of you at all, it doesn't necessarily mean that she thinks badly of you. It simply means that you have the opportunity to meet someone. You don't have this performance anxiety that has to take control of you. Again, you interpret the thoughts and beliefs of others without adequate evidence. I'm telling you this as a researcher, as well as a psychologist. You cannot read people's mind, okay? Careful before you do that. Connected to this, fortune telling, the expectation that a situation will turn out badly without adequate evidence. Now, there's a time frame component here, okay? Not only you're worrying about the here and the now, but you also try to predict the future that you yourself do not possess yet. Now, in this case, fortune is connected to fortuna in Latin, in the Latin or Roman tradition, so destiny or manifestation of something that will occur in the future, not fortune as in luck per se. Okay, so predicting an outcome. Emotional reasoning, the assumption that emotions reflect the way things really are. Okay, assumptions. Okay, I feel like a bad friend, therefore I must be a bad friend. This is also very important, not because emotions should be discarded or disregarded, but because you cannot rely on them alone. That's why if you don't have a solid philosophical background, at the very least, you should embrace the analysis of thoughts and emotions and actions, okay? Cognitive, behavior, at the very least, and feelings as well, right? So if you reason on the basis of your emotion, you might misinterpret reality, okay? I feel offended, I feel hurt, therefore what you're doing to me is hurtful. That is in itself a logical fallacy, which will hurt you more in the end, okay? Or the opposite, you might minimize your emotions. Everything about your emotions is telling you something is wrong, but you try to ignore them. So you had to find balance. Disqualifying the positive, recognizing only the negative aspects of a situation while ignoring the positive. One might receive many compliments on an evaluation, but focus on the single piece of negative feedback. How many of us experience that? Okay? I am totally guilty of doing that. You might have wonderful outcomes, in academia, for instance. You might go to college, have all good grades, and then there's one test where you really got a bad grade, and you can only think of that. Or you go to a party, everybody says hi, except that friend that doesn't even acknowledge you're present, and you cannot help but ruminate about all the reasons why this person might have treated that way, okay? Or in a social setting, you think that the system, the nature, your environment, your society, for the most part, does things quite well, but there's one thing that in your estimation, it's not good, and that takes over everything about your life. So you're disqualifying the positive, okay? And this is both extreme focus on one thing while at the same time simultaneously ignoring the positive, okay? This is to some extent connected to the should statement. Another very poor joke that psychologists say all the time is, I should all over myself, okay? They believe that things should be a certain way. I should always be friendly. Now notice that this it's not in itself ontologically false, okay? As in, I should always do my best to treat people with love and respect. Yes, that is correct, okay? Or I should always do my best to understand where people come from. Yes, those are true statements. The problem with should statement is that they're not equivalent to action yet. If you spend your life saying, well, I should really study more, I should really get myself into a balanced relationship, I should really get a job, I should go to college, I should get married, I should get divorced, you don't do anything. You're contemplating what you should do, but you're spending too much time and effort doing that, okay? So you believe that things should be a certain way, but you don't do anything to change the situation, okay? All or nothing thinking is black and white thinking. Thinking in absolutes, such as always, never, every. Example, I never do a good enough job on anything, okay? The problem with this type of thought process is that it seldom reflects reality, okay? You need to view reality in a more gradient scale spectrum in this sense, okay? When you interpret things, okay? Because we're talking about your thoughts, all right? Careful here, okay? Now, there's lots that we could add to this thoughts and cognitive distortion, but this is just a general overview of how you will approach your patient and yourself if you catch yourself or your patients, being caught into one or more of these automatic thoughts. As I mentioned in previous lecture, having automatic negative thoughts or cognitive distortion in itself, it's not indicative of pathologies. We all engage in this cognitive distortion from time to time. In fact, most of us will engage in multiple cognitive distortions simultaneously or within the same hour sometimes. But it's really helpful to have this, again, stoic appreciation for this separation from thoughts and interpretation of reality. Now, I wanted to give you an overview of the differences between the two big sisters at this point, two big siblings in the US for psychotherapy, CBT one side and dialectic behavioral therapy. I did mention dialectic behavioral therapy in the past. Perhaps we could just spend a few more minutes on it. DBT really is you could say an evolution of CBT. It originated from CBT, and it's one of the main contribution to psychology from Dr. Marsha Linehan. She was a researcher at the University of Washington, and as it implies, this dialectic is in itself a borrowing from many philosophies. You might be familiar with Hegel, the Hegelian philosophy, dialectic with thesis and antithesis and synthesis. So the idea is a synthesis or integration of opposites, okay? And you have different modules. So you have those four areas within dialectic behavioral therapy, especially in the context of mood disorders. DBT is very, very often used for mood disorders, personality disorders, suicidal ideation, cluster B personality traits, borderline. So you have a core of mindfulness, which usually lasts 2 weeks in DBT, and then you have interpersonal effectiveness for about 6 weeks. Then you have another 2 weeks of mindfulness, and then you have emotional regulation skills for 6 weeks, and then another 2 weeks of mindfulness, and then distress tolerance for 6 weeks. Okay, so the idea is to have this balance between what Marsha Linehan calls the reasonable mind and the emotion mind. These two extremes: reasonable mind, facts and logics. Okay, but without any talk of emotions or feelings. And then the opposite, the emotion mind. your emotions control everything about your thinking and behavior with no reason whatsoever, and the balance is the wise mind. Okay, this experience, this common sense. Sensus commun is the higher sense. Okay, this inner knowledge. Okay. So, and again, if you want to find out more about DBT, I'll be happy to target that more in depth. But in this slide, this is just an overview. So, again, CBT, Ehrenberg, Ellis, and all the ones that we just mentioned, focuses on reasoning and rational, as most commonly found in Stoic philosophy and the Socratic method. Socrates asking questions, the Maieutic method as well. Because you're allowing a thought to be born, so to speak. You're carrying a thought to its full conclusion. So you keep asking questions to verify whether those thoughts make sense or not. Okay? DBT, dialectic behavioral therapy, combines standard psychotherapy with mindfulness skills derived from combination of Zen Buddhist and Catholic monastic practices. Now, there's a lot to CBT and DBT, and this is a summary. But again, in terms of the comparison, there are a few things we could say. Like CBT is an action-oriented form of psychosocial therapy that assumes that maladaptive or faulty thinking patterns cause maladaptive behavior and negative emotions. Maladaptive is another term that you will hear a lot in psychotherapy. It is, to some extent, a bit oversimplistic. Because not everything about our behavior and thoughts is about the way we adapt to situations. This has also to do with the way philosophically you understand your life. You just don't adapt to things, because this is, as you can see, this might be perceived in an extreme way. Like either you focus on productivity, you're a productive citizen, otherwise you're not intrinsically worthy as a person, which is really, really a bad idea, ethically speaking, especially if you're dealing with patients that suffer and need your help. So being maladaptive might be an oversimplification, but the general idea is that you are adapting yourself to the optimal situation. And if you're maladapted, that means that you need to work on all the things we mentioned before. DBT, dialectic behavioral therapy, instead, it's a specific type of CBT, or an evolution of CBT, which was originally developed to help better treat borderline personality disorders and chronically suicidal individuals. So while CBT is this big umbrella for mental health problems, issues, diagnoses, presentations, etc., DBT focused more specifically on those issues, also because Marshall Linehan had a direct experience with them. So it's also a different history behind these two. In CBT, you have anxiety, depression, and substance abuse that can be treated. But because you're talking, utilizing thought processes, these can also expand on other presentations. Now, of course, if a patient is presenting to you with a full psychosis, the person might not be ready, both in times and presentation, to do a CBT exercise, a worksheet of CBT. But the point I'm making is that as long as something is involving thoughts and behavior, then CBT can be applied, especially in a short term, for instance, in acute, few weeks inpatient psychiatry session. DBT, suicidal or self-harm motives, and multiple complex difficulties in life are among the things that can be successfully treated with DBT. Now, when we think about success, we think about research, and we will have to navigate that a little more. Other differences: CBT, a short-term, goal-oriented therapy. The goal is pretty straightforward, versus DBT tends to be a little longer, which does not mean that you can also use a DBT worksheet in an inpatient psychiatry unit, but usually because of the structure and the manual focus on these 4 main areas, it's a little more constructed over time, so it's a longer process. Other consideration, the last one in this slide, CBT helps to identify, analyze, and reorganize unhealthy and negative thoughts in people, so recognition and labeling. And DBT, positive interpersonal relationship, stress management, accepting the reality, and proper control emotions are targeted. You can tell that there is a spiritual, mindful, meditative, prayer-like presentation here as well. This acceptance, this inner work that nurtures all of the above, the dialectic you perceive inside of you, the work on boundaries, for instance, with others, the work on perception, emotion, etc., etc. All right, so in the next slide, I'm asking this other question. Are all forms of therapy the same? How about therapists? Big controversy here. You will find a variety of studies that I will be happy to provide you with if you're interested. That seems to indicate very different outcomes, very different presentations. So some studies say that the best way to deal with mental health disorders is to have both medication, so pharmacological intervention, and psychotherapy. Now, this seems to be the standard, at least in the US. Some studies appear to indicate that psychotherapy is much better than medications. Some studies seem to indicate the opposite. Some studies seem to indicate that none is really helpful, to the point that certain meta-analyses appear to indicate that after a few years, doesn't matter what medication you take, how you take them, whether you interrupt them or not, nothing changes. And the same thing can be said about psychotherapy. What can we make of this? Well, first of all, I think it's a safe assumption to make that there is no such thing but proper individualized practice. As in, the way I'm teaching you this course is, well, first of all, an introductory level of psychology, but also it should be viewed as not a direct practical application, because each patient is different. But the general idea is this: if a person is able to be understood, or at the very least supported in the healing process by virtue of venting, opening up, discussing things, that in itself is positive. This does not, however, mean that every person providing this treatment is trained enough or has, for lack of a better term, proper philosophical, moral, and ethical principles according to which to treat the patient. It's a minefield, because of course you don't want to project your system of belief on the patient, but if you have no system of belief whatsoever, or at least that's what you think, things can be going in a very wrong direction. So if the goal of therapy is to treat, to heal, or to cure, or simply to support a patient in her or his healing process, life, or recovery, which form of therapy should one choose? I want to mention two very problematic directions here. First, misleading or dangerous approaches in therapy: unsolicited, manipulative, compulsive, or unskilled. Okay. So there are differences in training. Okay, a psychologist, it's not the same as a psychotherapist. A psychotherapist can also be a psychologist, of course. A psychologist is, if clinically trained, also a psychotherapist. A psychiatrist is not the same as a counselor. A counselor is not the same as a coach. Some of these professions are regulated. Psychology is regulated, psychiatry is regulated, coaching is not, or definitely not regulated with the same standards as psychology or psychiatry. What about counseling? So training makes up for a huge portion of that. But training itself is not enough, because we have huge power over our patients or clients, okay? So we have to be extremely careful about any form of non-fully aware, sometimes even unaware to the therapist itself, manipulation or unsolicited advice. And that's why I want to bring you the dark triad to your attention. This is part of the research that my team and I have been doing for many, many years, and I'm also very interested in, because it has to do with very problematic application of pseudoscientific factors, not just in therapy, but in the social realm in general. The dark triad is psychopathy, Machiavellianism, and narcissism. Okay, let's start with the first one: impulsive, emotionally cold, remorseless. Example: body language, inappropriate, or lack of emotional repression. Machiavellianism, for the Italian writer Machiavelli. Manipulative, self-interested, domineering. Example: body language, dominant, expansive posture, narcissism, we talked about this before, grandiosity, perceived superiority, and entitlement. Example of body language, first person pronouns, focus on self in conversation, me, or I. Now, this dark triad, it's something that we will discuss more in depth, but it's something that unfortunately can be noticed in those very people that claim, sometimes consciously, sometimes subconsciously, to know what's best for you, what's best for your family, what's best for your community, your school, your society, your politics, your country, etc., etc., etc. These are risks we always encounter. We are fallible as human beings, okay? And I mentioned this not to point fingers at any type of institution or profession, okay? It's something we just need to be aware. If we treat someone, okay, this is complex enough of a task if the person is asking us to be treated, to be helped. But we should be even more aware of those fallacies and those problems if we're telling people what to do, what to think, and what to feel if they didn't even ask. And we go out of our way to verify whether what they're doing is in any shape or form hateful or offensive or misleading. And we are actually presenting to the world itself the thing we should treat people and train people not to do. We are actually applying all this cognitive distortion. We see evil everywhere. We magnify things. We get obsessive about finding the mistake, finding the hateful statement, finding the problematic presentation, etc., etc. So just as much as I mentioned last week, I always use the example of firefighters because I used to be one, a volunteer firefighter for 50 years. Just as a firefighter tends to see fire everywhere, and sometimes there is none, a psychologist, a counselor, a clinician, a doctor, a psychiatrist, etc., might fall for those things as well. And these are very, very important factors to consider. I'll talk more about that, about this problematic dark triad. But for now, I just want you to familiarize with these two perspectives. Okay. Now, so let's sum up what we said so far. So we talked about all this form of therapy, and we talked about the behavioral aspect, the cognitive aspect, this interpersonal, patient-centered. Now, when we think about some of these applications, you also have to understand what the main goal is. For instance, if you think about conditioning, right, and you go back to this applied behavioral analysis, this is used, for instance, with children on a spectrum, with autism, nonverbal children, and the idea is that you shape your patient's chosen behavior to look more like a desired behavior, right? So you reward behaviors such as, sitting with someone or making eye contact with children, and then you have this token economy where you give praise and you give reward as quote unquote tokens that can be collected and traded for rewards later. And the issue is that you might replace normally occurring beneficial and positive behavior with praise for the behavior, so that the behavior might actually fade away because the child will just associate that with the reward, not with the pleasure that the child gets from the behavior itself, okay? So what other problems or criticisms can we say about this psychotherapeutic approach, especially within this behavioristic model of therapy? Well, one would be like, does it work over the long run? How long you go from this psychoeducational element where you teach the patient how to review things to the ability of the patient to work on their own. And there's also an ethical component, because of course, what about this manipulation that we just said and this cognitive triad? So it's hard to be again, an all or nothing judgment of everything we said there. And the same applies to other things such as, we mentioned integrative therapy. So EMDR, we already mentioned that, the eye movement desensitization reprocessing, it's a combination of all things. So what happens in EMDR is that you as a therapist, you will wave your finger or a light in front of the eyes of your patient, and you do this in order to integrate past and present and the two hemispheres, right? So one of the issues is EMDR might be shown as effective in certain studies and really not in others, but it's not, one of the issues that even if it's successful, it might not be successful due to the desensitization and reprocessing in itself, okay? So the same could be said to some extent to other techniques such as meditation, body scans, guided imagery. They work, but sometimes we are not presenting the process according to which they work as indicative of causal factor, okay? So that will be different like with heliotherapy or light exposure therapy, for instance. Because we do have also a biochemical understanding of why this could be effective. Think about vitamin D, think about light exposure itself, and how about the effects on the processing on a biochemical level of serotonin and dopamine for depressed individuals. So that is why light exposure therapy can be very beneficial for depression and even for SAD, for seasonal affective disorders. And of course, when we talk about psychotherapy, we should also think about biomedical approaches, okay? So you have talk therapy, but also the integration of the biomedical model to change the brain as you experience this therapy. Now, we mostly talk about adults here, but I would also like to mention a few things about ACEs or ACEs, adverse childhood experiences, which are essential to at least know in general if you are interested in one day in practicing psychotherapy. So what are adverse childhood experiences? There are potentially traumatic events that occur in childhood. Now, this is not a course in developmental psychology, so different theoreticians have different labels for what childhood is, but 0 to 17, so pre-legal adulthood, that's what usually it's defined as childhood for the perspective of ACEs. So ACEs include all types of abuse and neglect, as well as parental mental illness, substance use, divorce, incarceration, and domestic violence. Adverse childhood experiences have been linked to risky health behaviors, chronic health conditions, low life potential, and early death. As the number of ACEs increases, so does the risk for these outcomes, okay? So in this slide, you can see that there is plenty of research and there is a lot of influence in the time being, the here and now, but also over time, okay? As you can see here in this pyramid, from adverse childhood experiences to disrupted neurodevelopment, okay? To social, emotional, cognitive impairment, to adoption of health risk behaviors or risk-prone behaviors, disease, disability, social problem, and of course, early death, okay? So it's very, very important to understand that everything plays a role. So in this sense, looking back at family life, household challenges, abuse and neglect, all play a role. No man is an island, okay? All right, so in the last parts of this slide, I mean, there are a few more things I want to say, but I mostly talked about psychology, more specifically about clinical psychology in this course, but I'm just gonna sit here. But it's also important to understand that there are more things that one can encounter in mental health. Yes, psychologists are the primary professionals in this field, followed by psychiatrists, followed by counselors, mental health practitioners, coaches, etc. And so it's important to understand that there are different ways to apply psychological knowledge and different theories. There are so many that we could spend multiple lectures on each of them, The first one that I want to review with you is SDT, or self-determination theory, which is centered on the belief that people also have innate psychological needs that are the basis of self-motivation and personality integration. I did not write this in the slide, but many view SDT as a reaction to extreme behaviorism, extreme reductionist conditioning, also a reaction to Skinner, really, and Watson and James to some minor extent. And the two authors, Desch and Ryan, are very much quoted, especially in parenting courses and resources, child psychology, developmental psychology. So if one day you're going to be a parent, or maybe you are a parent already, you will see the application of self-determination theory quite in depth. It's not the only one. It's always good to have multiple theories at once, but it's one of such theory that can have the replication, especially in childhood education. So SDT identifies 3 universal and innate needs that, if satisfied, allow optimal function and growth. Notice, we are not talking here about anything on the level of morality or ethics, although those things can never be completely ignored, but this is quite different than what we said last week about Abraham Maslow and Robert Spitzer, for instance. It's quite not as profound, but it's very, very applicable. So as young parents trying to navigate the needs of your children, I think it will be a good idea to incorporate some of this. So what are these 3 universal and innate needs? Competence, relatedness, and autonomy. I want to give an example for each of this. So if a child is behaving quote-unquote improperly, okay, so the child might have a temper tantrum, doesn't want to do anything you ask the child, assuming that what you ask the child is good, is morally good and proper, okay. The need for competence really means that the child wants to learn how to do it himself or herself, okay. Think about tying one's shoes, okay. Yes, you need to show by example, you need to lead by example, but if you want to take away the child's freedom from doing it himself or herself, then the child's competence is unfortunately negatively affected. Need for relatedness, well, we all have that, more or less, we have different variation, but this is where you kind of take a step back from judging in a harsh sense as a parent, and you try to connect with the child. Okay, maybe the child is not able to emotionally understand what you're telling the child. Maybe you are ethically and morally correct and say, no, you must do this because otherwise, bad consequences will happen. For instance, I don't know, the child just was eating and made a mess, and it's all wet and it's going out and 20 below, and you're afraid the child might get sick. But at the same time, you need to connect with the child because reasoning about that might not be the best strategy at the very moment. And then the need for autonomy, similar to the need of competence, but this time more on, the emphasis is more on, let me do this on my own. Don't tell me what to do. I need to learn how to do it, but I also want to be alone in doing it. I want to be able to make decisions for myself. Now, this is tricky because if you ask me, in this modern day and age, we are completely going in the opposite direction, where there's all autonomy and no proper judgment or education, okay? Which is really, really a bad idea. Research is pretty clear about that. It's really a bad idea. But a good example might be if the child wants to experience full autonomy is, let me understand for myself what I can do with this. So giving options. Example, the child spends far too much time with screen time. And if you ask me, what's the best screen time? None, especially a child below the age of 2.5 or 3. No screen time whatsoever. They don't need it. It's extremely dangerous for their developing brain. But let's say the child is getting older, child might be 10 or 11, okay, and you're trying to navigate how can you promote healthy brain development, emotional development, cognitive development, while also giving the child the ability to make some minor decision. You're not going to ask the child, well, what do you think it's the
best amount of time you should spend in front of a TV or computers or iPads or phones. You don't do this because the child is a child, okay? You don't ask that question, but you give the child the option. For instance, if the child wants to watch TV now and you know the child has to finish her homework, you might say, okay, let's give you an option. You can watch TV now, and you will ask the child what the child would prefer. Would you prefer to watch this movie now, but then you're not gonna watch anything tonight, or would you prefer to postpone that and watch the better movie that's on tonight, for instance, okay? So the child has this level of autonomy to decide for herself which option is best. Should we pick up these toys now, or would you prefer to do it later? Now, this is not the optimal scenario because the later part is in itself problematic. So I only use this example in general, but the child itself also does not have the same capacity for the comprehension of time as yourself. So as a parent, you might find yourself disappointed where the later option never happens. The children will do that. The children live in the here and the now. So the child most likely will say, I'll do it later, and then later never comes. So you can give them two equally balanced perspectives, okay? So what would you like to do? Would you like to go play out with your friends, or would you like to get an ice cream, okay? They say, I want both. You know, you can give an option so they can work on their autonomy, okay? And it's a basic thing, you know, if you have options that whichever option you picked it yourself. I didn't tell you which one to do. I'm not gonna tell you, you must clean up or else, okay? So you have an option. If you clean up now, then you have more time later to play with your friends, for instance, or you can decide to clean up later, but then you have to shorten up the time you spend with your friend playing. So you give them an option, okay? So more in details, humans are inherently proactive with their potential and mastering their inner forces such as drives and emotions. Now, this is an assumption of self-determination theory, which might not be the same in other forms of psychotherapy, other form of philosophical background, okay? The fact that humans are inherently proactive. But it applies to what we said about this competence. Humans have an inherent tendency toward growth, development, and integrative functioning. Again, this integrated, this shared, this relatedness, okay? And finally, optimal development and action are inherent in humans, but they don't happen automatically. You need to lead by example, okay? And that is why it's also connected to other things such as what we said about Bandura, for instance, or Vygotsky, and the idea that we are social creatures as well. All right, let's continue. Goal-setting theory, also very useful. I would say useful in any branch of psychology, but perhaps in fitness, sports, addiction and recovery, all these areas for well-being are really, really useful. Goal-setting theory highlights the importance of goal setting, as it implies, by proposing that those who set goals for themselves are more likely to achieve success than those who do not. Researcher Edwin Locke was instrumental in proving goal-setting theory to be true as in scientifically valid, okay? And he proposed 5 principles of effective goal setting. Now, this is similar to what we said a few weeks ago when I showed the abstract from My Big Fat Greek Wedding. So this idea that if you set goals for yourself, you're most likely to have a higher success because it comes from within, okay? But there are 5 principles of goal-setting theories. Clarity. Goals need to be clear and easily understood in order for them to be most effective. You can be too vague, as in, I just want to get better. Well, you have to be clear. And what do you mean clear? Well, I want to have better sleeping patterns. Okay, be more specific. I want to sleep at least 6 hours a night, okay? Clear goals. Challenge. Good goals have a high enough level of difficulty that you actually have to push yourself in order to achieve them. I want to exercise, but I only want to do it on odd days every other month. Well, this is not challenging enough, okay? And this is connected yet again to the work by Csikszentmihalyi in regard to the flow. Commitment.
Without a high level of commitment, it's difficult to achieve any goal, especially those that are somewhat challenging. This is very important, especially if there is a pedagogical element. You need to stick to it, okay? You need to commit to it. And this is true for every aspect in life, okay? Think about relationships. You could have relationships that are easy to burn, but also easy to burn out, okay? You need to commit. You need to work on this delayed gratification as well, okay? Because otherwise nothing will be shown for yourself, right? That you don't achieve the same level. Think about learning how to play piano, for instance, okay? And of course, this is also part and parcel of the negative effects that unfortunately social media have on young minds. This fake idea, entirely false, that you can become a wonderful, I don't know, a musician just because I play piano within few sessions. Okay, you see the end product on social media, and you just think that you can skip through and cheat your way to greatness. Well, unfortunately, that doesn't work, nor should it work, because it really removes the benefit of the reward mechanism, the pleasure, the hard work you put in over time, commitment. Feedback. You need to be able to receive information about how well you're progressing toward your goal. This information can be used as a motivator, or it may be signal that your goal is either too easy or too challenging and needs to be adjusted, okay? You need to be able to be a research scientist for your own well-being. How are you going to monitor that? For instance, if your goal is to be more sociable, okay? Now this is a big umbrella. You may say, well, I want to learn how to be in the presence of people a little more, okay? Okay, set a goal. Every day I want to go to a public library for half an hour, and then maybe the following week is going to be an hour, and then maybe library is too quiet, I don't have much opportunity for talk, I want to go to free public lecture once a week, and then maybe twice a week. So you give yourself specific ways to monitor your improvement. Okay? So this constant feedback. Okay? I mentioned this socializing aspect because it's so important, especially after what happened a few years with the COVID-19 pandemic and the progressive isolation that young people especially perceive in their everyday life. Finally, task complexity. The more complex a goal is, the more time you need to give yourself to achieve it. Good goals don't have to be complex, but understanding how complex your goals are is an important part of planning how you will achieve them. There's a bit of strategy here. Well, first of all, you might think at first that task complexity contradicts clarity, right? You say, well, wait a second. First you tell me that the goal is going to be very clear, essential, not vague. Complexity requires a lot of moving pieces, yes, but you can also review that. Example, in terms of self-esteem strategy, let's see, a person with a heavy depressive presentation might find simple tasks such as waking up in the morning, preparing breakfast, or fixing a sandwich extremely difficult, okay? So rather than saying, you put it on the list of things you need to do. I think I mentioned this in week 1. Rather than saying, either I accomplished this or not, as in I was able to prepare to fix myself a sandwich or not, you try to work on the complexity. Well, I was able to go and buy bread, not just any random bread, but maybe organic, multi-grain bread, and then I went and bought some mayo, organic mayo, locally sourced, and then some lettuce and some tomatoes, for instance, and then I went and I didn't just get pre-made chicken, I actually cooked the chicken and sliced the chicken and I put it in and I put it all together. So you work on the complexity itself, and the more you do that, the more you expand your skills, okay? You might be overwhelming to do it all at once, so you might do this in steps, but the idea is that understanding how complex your goals are is in itself an important part of how you will achieve them, okay? Next slide, the trans-theoretical model of change, Di Clemente, one of the authors. Prochaska and Di Clemente, the two main authors. It's also called the stages of change model. This is very useful, especially in applying psychotherapy to addiction and recovery, because first of all, it moves away from this linear model, linear understanding of history, whereby either you achieve a goal or you go back to stage one. Now, this is not necessarily a bad idea overall. Think about how you will get a medal from AA, Alcoholic Anonymous. You cannot cheat your way through it. You're sober for a year, let's say, and then you get your medal, 1 year medal. But then if you have a relapse, you don't get to keep the medal. I mean, you might keep it for yourself, but you don't get the same appreciation or badge, so to speak. You need to go back to stage one. You cannot say, well, I was sober for 3 years, but after each year I relapsed. You don't get to say 3 years. You start from scratch. So there is an element of psychological value in going back to stage one, which is very similar to what happens in many spiritual and religious traditions when you try to cleanse yourself and you start from scratch. Think about confession, for instance, right? When you give up all your mistakes, all your sins, all the bad stuff you've done, and then you restart as a blank slate, okay? And you try to expand on that. The downside of this perspective that I just mentioned for AA is that if you relapse, you might be at a higher risk of depression, negativity, and low self-esteem, because you really feel that you're a failure. You start from scratch as if everything you've done so far is nonsense, was useless. In this model, instead, as you can see, relapse is just one part of the whole cycle. Relapse, fall back into old patterns of behavior, is just you're off, but then you can jump back on the train, okay? You can visualize this as a train. So you have all these arrows in different colors, and inside, okay, this looks like a Fibonacci series in mathematics, okay, or golden ratio. Upward spiral, learn from each relapse. So you could view this in a kind of eternal return. You have this sequence, this cycle, but you have multiple cycles that go up as in a pyramid, or rather in a cone, so to speak, okay? And you use this to better understand where the patient is coming from, so that you don't just tell the patient what to do, you understand how to approach this, and you allow the patient to come back to you with solutions, okay? And this is similar to what we said earlier about children. You cannot give the child a lecture on the ethics of cleaning up the mess in their room. They're not ready for that. They're not in that place in their life. So you need to be at their level, okay, lead by example, and navigate this complexity with them so that they can be successful in monitoring their behavior and their emotion, their thoughts, to change the behavior that they need to change. So each of these steps is a different type of presentation, which as a counselor, as a clinician, as a doctor, you need to understand to better equip your patient with the right skills, the right tools. So pre-contemplation, no intention of changing behavior. So you need to understand that the client might also come to you, not because he or she wanted to, but because it was court ordered, or the family was nagging him or her to see you, and the patient doesn't really want to do anything. This is something you need to understand as a therapist or as a counselor. You are not a wizard, okay? You don't have any magic powers in this case. If a person does not want to do anything, you can only plant the seed, but it's really entirely up to them to make the change. You cannot force anyone to do anything. In fact, this is not because you cannot, because you're not able to, okay? Nor you should not in that sense. The reason being is that, first of all, it might not be the ethical thing to do. We already talked about the dark triad there. Be very careful with the power. Okay? With great power comes great responsibility. But the other problem is that if they do it just to please you or because they fear you, then the behavior itself might not last, and it might create extra problems. And we mentioned some of psychoanalytic issues with transfer and counter-transfer. So that's generally not a good idea, okay? But if you plant the seed, the patient might go from pre-contemplation to contemplation. Okay? The contemplative state is an essential element of philosophy and theology for thousands of years. So it's not surprising we use this in psychology as well. What is contemplation? Being aware that a problem exists, but there's no commitment to action. It's almost like a conversion. Okay? Not necessarily a religious conversion or reversion, but you're planting the seed, and there's some level of discomfort that your patient is to navigate. So they don't want to do anything about it, but they're aware that something is wrong, okay? And this is important because the patient needs to feel some discomfort, needs to feel some level of pain, which is very different from some pseudo-scientific, pseudo-philosophical approaches where life is all about reduction of pain, discomfort, reduction of any type of challenge, okay? Creating a world that's completely safe. Well, that's not going to be good for you at the end of the day. You need proper challenges as well, okay? So you plant the seed, okay? They don't want to change. For instance, yeah, of course I know that smoking is bad for me, so why don't you quit? I don't want to quit, but why? And that's really frustrating to some therapists because they think that the thought is enough, right? Well, you know that's bad for you, so just quit already, okay? Or they might be actually doing even worse. Well, if smoke is good for you, it must be good for you. I mentioned this a few times this semester, right? So you plant the seed. At the very least, the client sees something wrong. The next step is preparation, okay? There's intent upon taking action. Notice they're not doing anything yet, but they're demonstrating, showing, I want to do something with it, okay? I don't know what to do. I don't know if I'm strong enough. I don't know how long it's going to take. But at the very least, I have the wish, the want, okay? You're already directing your thoughts and emotion in a very specific direction toward your goal. Out of this preparation, and the preparation should be supported, okay? As a therapist, you should ask questions, use the Socratic method. Okay, how are you going to prepare to do this? How will this look like for you? Tell me more about your week. How can you fit in, I don't know, 2 exercise sessions? How many would you like to do, etc., etc. Better open-ended questions that we will see later on, okay? And finally, action. Well, finally, not really finally, but after preparation, action, active modification of behavior. You do something about it and it's active. You don't change who you are right away, you change your behavior. So you are working on either replacing fully the behavior that was not healthy with a healthy one, or you target that. Maybe this at this stage might be a reduction of harm rather than substitution. Rather than smoking 10 cigarettes, you're going to only smoke 5. Although the research seems to be quite clear that as far as smoking, quitting cold turkey is more effective than trying to reduce. And even more so with alcohol, okay? As far as the research indicates, if a person has a strong addiction to alcohol consumption, it's really difficult to keep that at bay. Drinking sporadically once or twice, okay? It's all or nothing in general. That doesn't mean it's not doable. It simply means that the research, at least in the United States, okay, indicates that an all or nothing behavior, not an all or nothing thinking, as we saw earlier for cognitive distortion, seems to be more successful. All right, after action, you are, so to speak, cruising through. There's maintenance, right? There's this sustained change where the new behavior replaces the old behavior. Okay, so there's a lot of application of this. One of such applications is MI, or motivational interviewing. Now, motivational interviewing is a counseling style. Okay, it's a counseling style, but it's also a school of thought, an approach. And I'm very familiar with this because you can see this applied in a variety of settings, more specifically, more often than not, in healthcare, not just in psychology, but any form of healthcare. The way a physician, for instance, a primary care physician, a family doctor, might ask questions to her or his patients, but also in the context of businesses, for instance, okay, to motivate your coworker, for instance, or your employees, etc., etc. One more controversial application is within the realm of health coaching or health and wellness coaching, which it's a little more problematic because, again, it might
be contributing to the problem. Okay, I have a specific series of lectures about that, and also in terms of the scientific validity of the approach. Motivational interviewing alone is one thing. Motivational interviewing applied to health coaching, to coaching in general, to health and wellness coaching, it's a very, very different situation. So again, I don't want to cover too much, but just something to keep in mind. Also in regard to the very different requirements for certification and licensing. So this counseling design approach is developed in part by clinical psychologists Miller and Rolnick. In the US, motivation interviewing is usually attributed to these two researchers. It is based on Carl Rogers' person-centered or client-centered approach to counseling and therapy as a method to help people commit to the difficult process of change. Okay? Again, is motivation interviewing part of policy psychology or humanistic psychology? Well, it comes from the same background. But motivation interviewing itself, it's not psychotherapy, okay? Let's be very clear. People offering motivation interviewing don't have to be psychotherapists, and that's why it's important to distinguish the profession of coaching or counseling from the profession of clinical psychology or psychotherapy. From a legal, clinical, and even more important, ethical perspective, okay? They are not trained in clinical psychology, okay? Unless you are a clinical psychologist that might utilize some motivation interview techniques, okay? Although in that case, you have to be careful because the application of these techniques might serve certain areas of therapy, but they might not be useful in other areas where you need to be more direct, more judgmental, and more clear, okay? But let's see how this actually applies in general. So, first of all, there's a twofold process, okay? The first goal is to increase the person's motivations, and the second is for the person to make a commitment to change, okay? Notice there's a suspension of judgment here, okay? Whereby the counselor does not judge as much as a psychologist judges, because the psychologist has a higher moral duty to protect the patient in that sense, okay? The main focus of motivation interviewing, in practice, what motivation interviewing does is this acronym, ORS, okay? Open-ended questions, affirmations, reflections or reflective listens, and summaries, okay? Those are the main techniques. As I mentioned, quite useful to provide the patient with some nurturing elements so that the patient doesn't, close herself and himself up to your contribution. It's also a way to open up the conversation, which I would say is extremely useful, for instance, in the areas of public discourse. In our society, especially in our country, we're becoming so progressively divided that we don't even sit and have a nice conversation to hear the other person's perspective. We already judge the person and put them in categories, in labels, in boxes, in groups, in parties, without actually listening to what they have to say. So this technique of open-ended question is really nothing new. Open-ended questions is the Socratic method, okay? So motivation interviewing is only new if you forget the last 3,000 years of history, okay? So nothing new under the sun. An example of open-ended question, okay, might be something like that. Rather than asking the person that comes to you because they struggle with self-image, okay, and they already share with you that they want to exercise and work on their diet, rather than asking a direct, closed question. So, did you exercise? Which can only be answered with a binary yes or no. You ask, how was your exercise last week? Okay? Or how many times did you exercise? Now, it could be possible that they did not exercise at all, so they might answer still with, I did not exercise at all. But at the very least, you're stimulating an open response, right? Because if the person has to answer to you, no, I did not exercise, they already feel bad about it. They might even feel troubled by the fact you're asking them, and they might even feel less prone to continue the conversation, just close up. So an open-ended question allows for a warmer approach to what you have to say, okay? So this is one of the techniques. Then when you think about affirmations, you're actually affirming not what the client's behavior, thoughts, or overall emotions are, you notice them, okay? And you help them reframe them. This is truly important. We, as therapists, as psychologists, are not there to affirm our clients because they might make mistakes, okay? As I mentioned multiple times this semester, okay? It's like a broken record now. There are good and bad ways. We have to be judgmental in this sense to feel, think, and behave, okay? Not everything is relativistic. So, but you need to affirm certain things that might have done well, okay? For instance, you are affirming the fact that they were driving to the gym, for instance, okay? Or even better, you're directing conversation to what is happening at the moment, okay? So, for instance, if the person is not really presenting you with a big smile, okay? Having this positive affirmation simply means, well, I appreciate that you're willing to meet with me today, right? And you keep doing this throughout the conversation. For instance, if they're thinking about what else they can do to target their well-being, okay? They don't do anything yet, so they might be in between a pre-contemplation phase, etc. But you can say, well, you clearly are a very resourceful person, okay? Or if they say, well, I had this, this person came to me and started calling me names and this and that, and now I feel so frustrated. But maybe next time I should just ask them to stop talking to me. Now, if you see that there's any positivity there, you might just say, well, that's a good suggestion, okay? And in the end, an affirmation is also not judging what they're doing, because you're not affirming their behavior, because the behavior might be bad, okay? But you are affirming what is happening. For instance, well, I enjoy talking with you today. Okay? This is what we mean by affirmation. So be very careful in the way being affirming is different in different clinical settings, okay? Now, because you're trying to navigate complexity, you go back and forth between the O and A. So with open-ended questions, but by open, it doesn't mean tiptoeing around the problem. You still need to ask the question. So if the person is complaining about all the things that go bad in their life, then you need to ask, how would you like things to be different, okay? So it's on them to clearly define the goal, okay? Or you have to navigate this ambivalence, right? So what do you think will happen if you stop smoking? What do you think will happen if you lose your job? What would you like to focus on next, et cetera, et cetera, okay? So that's the going between the O and A. So when we think about reflections or reflective listening, we could just call it listening attentively, okay? And this is part of the soft skills that are difficult to learn, but even more difficult to teach without an example, okay? So you might use those sentence starters such as, well, it sounds like you have been working on this for the last 3 months, okay? Or the person might actually go all different directions. You're trying to bring it back to the main focus, and you are repeating, reframing what they're saying, right? So you repeat, you paraphrase, you reflect. So you're wondering if keep doing what you're doing will have an impact on your children. So it sounds like on one side you want to do this, but at the same time you have that, okay? So you're working on multiple things at once. And then you have summaries, and summaries are a combination, you could say, of reflections. So you might say that a good way to approach any type of conversation is to make sure you understood the person correctly, okay? And there's a problem with our modern debate. The assumption is that if it's a debate, I had to present my thesis, you present yours, let's see who wins the debate. It is not about winning, it's about learning, okay? So if a person says, well, I believe that this strategy doesn't work and it actually harms people. So you might say, well, let me see if I understand you so far. So this is what I heard. So if you apply A, B, and C, then D, E, F will happen. Please tell me if I miss anything, if I'm misinterpreting.
And it's a really good place to start, okay? Which also gives the chance to the patient to better understand where they're coming from, because they might come to you and they really have no idea, first of all, of what you're doing, but also what's the purpose of it all, okay? So why you're doing there, okay? And there's many other things that connect motivation interviewing with everything we said about human psychology, humanistic psychology, or positive psychology, because you still have these needs. You have autonomies, you have acceptance, you have adaptation, empathy, and then evocation, right? Because you have all these frameworks, and there are also assumptions. So there is ambivalence about all patterns of behavior, especially addictive behaviors, and change thereof is normal and constitute an important motivation obstacle in recovery. For instance, okay, rather than telling a person that wants to quit smoking that smoking is bad, which is first of all obvious, common sense, and doesn't really change the behavior, you ask the patient what's good and what's bad about smoking, okay? So you create this tension between these two poles. So on one side, smoking gives you a chance to relax. It makes you more prone to listen to the other person. You're more focused at work. It gives you a chance of taking a break. It gives you something to do with your hands, all these kind of things. But on the other side, what I'm hearing you saying is that if you keep smoking, you will lose a lot of money every month. You're feeling less fit, and this prevents you from playing with your kids, etc., okay? So ambivalence can be resolved by working with your client's intrinsic motivations and values. So you don't judge, you don't affirm, but you understand where they're coming from. Example, they love smoking, they think it's all about smoking, but they love their kids as well. Careful here, you're not using like a guilt trip perspective. Well, if you really love your kids, you should quit smoking, because otherwise you would have done that already, okay? Now, fear of the consequences and guilt is sometimes the optimal way to go about things, okay? We have to remove this idea that feeling guilty and feeling bad about something is intrinsically bad. No, you should feel guilty, you should feel bad, okay? And you should also have some level of fear for the possible consequences, okay? But you can also add the value. For instance, so it sounds like you really care about your family. How does that look like if we apply what you just said? Okay? So how much more time and energy will you have to play with your children, since you just said that you praise and value that aspect of your life, okay, if you quit smoking? And then the alliance between you and your client, your patient, is a collaborative partnership to which you each bring important expertise. And this is very important because we need to distinguish the profession. A coach is not a psychologist, okay? So you bring both expertise to untangle the problem as a coach, but as a psychologist, you need to be in charge. Okay? All right, which doesn't mean that you are in charge in an authoritarian manner. I'm telling you what to do. I'm telling you what to think and what to feel. Not like that. But there is a different level of hierarchy if you're doing your job right. Finally, for this slide, an empathic, supportive, yet directive counseling style provides conditions under which change can occur. Direct argument and aggressive confrontation may tend to increase client defensiveness, so here the psychoanalytic component comes back, and reduce the likelihood of behavioral change. Okay? So all this together. Now, in the next slide, I did my best to combine all of this into a framework. I'm not a big fan of acronyms, as I mentioned before, but sometimes those are useful to understand things such as MI. So you have the overall attitude or spirit, general framework and attitude, theoretical understanding, autonomy, collaboration, evocation. Okay? And then you have these principles. Okay, roll with resistance. So if the patient is resisting advice, don't try to push it. Okay, you just go with it. Okay, go with it does not mean to affirm, as we have seen. You need to express empathy. It's not enough to think you're empathetic. You need to express it. Okay, it's the same thing as, well, my friends know I love them. But did you tell them? Did you demonstrate it? Well, they know that. Well, it's not enough. You need to express empathy. Okay, and develop this discrepancy. Okay, by rolling resistance doesn't mean that, well, whatever you're saying, it's okay. You need to develop the discrepancy between how they feel the problem is affecting their life now and in the future, and what it's doing for them, okay? And then you support self-efficacy according to everything we said so far about all these different forms of psychotherapy. Micro skills, what we just did, these ORs, these open-ended question, information, reflections, and summaries. And then you have these two elements, commitment and change talk, each of which has an acronym. The DARN CAT is the acronym that is used in motivation training. DARN CAT. DARN, change talk, CAT, commitment. So what is the DARN? Desires, ability, reason, and need. And you work on each of these to understand where your patient is coming from, okay? And you do this because you want to understand how you can work with the client, not to the client, okay? To understand where they're coming from in terms of what motivates them, what principle and values they have. And then in practice, how they're gonna commit to their goals. So commitment, intention, decision, activation, ready, prepare, and then specifically taking steps. All of this will lead to behavior change. Yet again, you're not judging the behavior as a counselor, as a coach, okay? But you help the patient navigating this new behavior that they want to apply, okay? Let's talk about integrative approaches to psychology, well-being, medicine, healthcare in general, okay? I will not spend too much time on each of this. Well, first of all, because I have other lecture series that I think I recommended in the past. If you are interested, I can direct you to those, but also because I want to focus on psychotherapeutic approaches more specifically. Now, the problem is that, like with everything else, psychology, psychotherapy is a branch, really, of healthcare and medicine, but also goes beyond the biological, biophysiological elements. So some of these therapies are integrative or complementary alternative in the sense they work more on the body than on, let's say, the mind or the brain, the spirit, so to speak. So some of them might not be as applicable. I will spend more time on those that are relevant to this course. And this is a list all in alphabetical order. You have acupuncture, anthroposophic medicine, so Rudolf Steiner and Waldorf School, etc., aromatherapy, art therapy, we'll talk about that, Ayurvedic medicine, biofeedback, bioenergetics, bioenergetic therapy, vector therapy, think of the work of Alexander Lowen, chiropractic medicine, which is different regulation in different areas of the world, faith-based healing. Now, I put everything in the same area here, Christian faith healing, religious, spiritual healing, and shamanism, just to mention that. I'm not claiming that those things are equivalent or as applicable or should be applied to psychotherapy. Dance movement therapy, deep breathing exercises, energy medicine, ethnomedicine, folk medicine or traditional medicine, guided imagery, which we mentioned a few times today, herbal medicine and phytotherapy, spagyrics, which is more the Greek alchemy, ancient Greek tradition, hypnosis or hypnotherapy, homeopathy, the work by Samuel Hahnemann in Germany, homotoxicology, magnetic healing, mesmerism, and animal magnetism, the work by Franz Anton Mesmer, massage therapy, meditation, mindfulness, mind-body medicine, this big umbrella, music therapy, narrative medicine, which, as I mentioned, is different than narrative therapy, naturopathy, Heilkunde, including the Neue Deutsche Heilkunde, the difference between a naturopathic practitioner, naturopathic doctors, or natural physician, as the German Heilpraktiker or Naturarzt, osteopathy, manipulative medicine, the Feldenkrais method and Alexander technique, pranotherapy, therapeutic and healing touch, very controversial, progressive relaxation, Qigong, Reiki, Tai Chi Chuan, TCM, TEM, TTM, and there are many others, of course, wellness therapy and yoga. Those are just a few. I would like to focus on the arts. Well, first of all, because they're the ones that are mostly applied in modern psychology, modern psychotherapy. And with arts, we should mention all arts. For instance, there is art therapy, but there's also dance movement therapy. To just spend a few seconds on the latter, the dance movement therapy is both a technique and a strategy and movement, okay? And in the US, it's defined by the American Dance Therapy Association, or ADTA, What is it? It's a psychotherapeutic use of movement to promote emotional, social, cognitive, and physical integration of the individual for the purpose of improving health and well-being. So yes, you can apply dance therapy, you can apply movement therapy, you can apply music therapy, okay? And within music therapy, the definition is given in the US by the AMTA, the American Music Therapy Association. So there is a difference between dance movement therapy that I just mentioned to you and music therapy, which is the clinical and evidence-based use of music intervention to accomplish individualized goals with a therapeutic relationship. I'm just reading from their website by a credentialed professional who has completed an approved music therapy program. Music therapy intervention can address a variety of healthcare and educational goals. And then, of course, art therapy is probably the biggest one, okay? Sure, you do have the American Art Therapy Association, but I'd like to mention a few things about art therapy really quick, because you have creative art therapy, you have expressive arts applied to psychotherapy, you have outsider arts, you have many other things. So I just want to give you a few examples here that I have created with some of my patients. As I mentioned multiple times, I wish I could show you some from my patients, but due to obvious reasons, I'm not at liberty to do so. In this first example here, you have some more of a narrative and even analytical perspective, where the patient is actually working on their visions or dreams or goals or interpretation of their life in a, I would say, analytical sense, in the Jungian sense of the term, whereby you can use symbols and metaphors and archetypes to imagine facing your challenges, and the challenge is like slaying the dragon, okay? And you need to defeat the dragon, your inner dragons, okay? And you can see here, this is very figurative. There's a castle, there's a river, there's some sort of aqueduct or a bridge, and maybe a religious building below, some mountains, and you interpret that according to everything we said about analysis, but also in terms of open conversation with the patients, okay? I mentioned this as an example. I would love to talk more about this. Please reach out to me if you are interested in art therapy or music therapy, etc., and I'll be happy to talk more in depth. The next one is one of the most common example, the lifeline or adaptation of the lifeline exercise. And the lifeline scenario is really an application of a visual version of a journal. So you can view yourself in a sequence, in a line, and then follow all the things that we previously mentioned. It's also stimulating to the patients to understand how they can look at themselves over time. And again, I mentioned this at the beginning of this lecture. Another one, also more oniric, dreamlike, figurative. This time, though, very different process in the brain. We want to integrate left and right hemisphere. So rather than using watercolors, oil paint, or acrylics, we use pens or pencils, so that you have more of a direct of work. And again, the purpose is not to create a beautiful artifact, okay? Although it's okay to strive for that as well, okay? You need to keep in mind this triad that I mentioned multiple times, the good, the beautiful, the truth, etc., but also to interpret symbols and mechanisms in life. And then another example here, this kind of Celtic knot pattern, which is similar to this focus-oriented attitude that, for instance, you have in the application of eurythmy in Waldorf schools to help children that are hyperactive. So you use this analysis as a way to make them more focused in the present moment, more embodied, more incarnated in their body. And a few more examples here, also kind of oniric or mandala-like, especially the last one, to present more of a integrative approach to the psychotherapeutic model. Again, not everything is art therapy, but this can also be really viewed as a way to integrate psychology, psychotherapy with multiple diverse approaches to healthcare.
Thank you. This concludes week 12. We talked about psychotherapy and integrative approaches to the therapeutic application of psychology. Please let me know if you have any questions, especially on each technique. I'll be happy to answer them. And I will encourage you to study and research a little more each of them to create a balanced approach to your own well-being, to better understand yourself, but also to decide, for the sake of your career path, which direction you want to take in your life. Whether you might want one day to become a full doctoral level psychologist, a clinical psychologist perhaps, if you're more interested in research, if you are more interested in overall well-being, you prefer to go into the counseling or coaching career, etc., etc. I'm here for you, and I will see you all in week 13. Bye-bye.